just by way of an introduction, that the DataLoch program is a regional program. So it's a data service that has been stood up as part of a wider City Deal service, the DDI program, so Data Driven Innovation Program in South East Scotland. So it's been partially funded by UK and Scottish governments, as well as the university itself. The Data Driven Innovation Program has an intent that is about building data capabilities and skills in the region. So that's really the driving purpose behind the Data Driven Innovation Program. And DataLoch specifically is a data service that brings together routine healthcare data for the South East Scotland region, working with experts and clinicians in the region to understand and improve that data, and then making it available via a safe platform for academics, clinicians, innovators, so researchers who are not necessarily based in the region, so based either in South East Scotland but also in wider UK and internationally as well. Critically, we are accountable to the public in the way that we actually manage that data. And have a public reference group that's a key part of the DataLoch data service that helps us understand exactly what the expectations should be from a public perspective. We are working towards a service that achieves these 5 things. So first of all, one that is swift and predictable in terms of access. So if we say this research project or innovation project will have data available in that secure area within a certain time frame, then that's when we want it to be available. We want it to be predictable so that people can plan their research. We want to enable comprehensive research that's based on an entire patient journey, so cradle to grave insights. We want to integrate social care, so this is the one that we have really struggled with. So social care data is at the moment fairly limited within the DataLoch service. We are largely healthcare based, but we are talking at the moment to a number of our local authorities in the area to integrate social care, which will really give an holistic picture of a patient's well-being. We have a service that includes a network of professionals, so data experts and clinicians who both support individual projects but also help us in terms of understanding the data and documenting that data within our metadata catalogue. And we work very hard in terms of adherence to FAIR principles, so making sure that the data is findable, accessible, interoperable and reusable from a research perspective. So that's really the fundamental principles of the approach that we've taken and have built over the last 3 years. Now, there are a lot of challenges to using routine data. So the first one is the biggest, which is the disclosure risk associated to both the granularity of the data, because we are talking about individual level data, and the sensitivity of that data. So we're talking about data that is very personal to individuals, and we have to remember that there's a person at the end of every line item within our database. So it's very sensitive data. We recognise that the social context of that data is often missing. So environmental data, social and community care data, wearables data, all of that would help to add some of that social context. But at the moment, that's very difficult. It's very messy data, so we work very hard to understand what the level of the quality of the data actually looks like and try and communicate that quality to our researchers and innovators who are accessing the data, so that there is an understanding and expectation in terms of where there might be gaps, where there might be some confusion in units of measurement or different coding being used in terms of capturing the data. And it's also very siloed, so it's fragmented across the ecosystem, lots of different health systems, generally disease focused, although not exclusively. So a lot of specialist systems that are being created in order to manage specific patient treatment pathways. So there is a key role for us in good quality linkage of this data across that ecosystem. And there are a few things that we need to do, therefore, in DataLoch to really support good quality innovation and research. The first is making sure that we are sourcing the appropriate data, that we understand the data quality from that data source. We work incredibly closely with NHS Lothian, who are our main data controller, to understand the various data sources, and then the next stage, improve that data where possible. So improving data includes improving the metadata to make sure that actually we are very clear about what the quality of the data actually is, and we do look to give a visibility to our innovators and researchers who are accessing the data about what the level of quality is and where there might be challenges in that data. There's a task in linking the data, so making sure that we have a single picture for individuals in terms of their healthcare that includes diagnosis, that includes treatments, that all takes them all the way through eventually into community care as well. We document that data within a metadata catalogue, structure it so that it is easy to access for research and innovators, and then make sure that it's available via a secure access environment. So each of those steps is something that we do within DataLoch. In terms of what the data coverage looks like, obviously from a multi-morbidity perspective, it's critical that we have data that covers all conditions, multiple conditions, from both primary and secondary care records. And I'll talk a little bit about the difference that having primary and secondary care records actually makes to the data coverage in a second. We also have common definitions, common phenotyping from the HDR UK code libraries using the caliper coded phenotyping. So that gives a sense of common condition phenotype standards. We include also laboratory test results and x-rays and other radiology within the data. So that gives us a good foundation in terms of conditions and diagnosis. We also have prescribing data, so prescriptions dispensed in the community. We are hoping to have inpatient prescribing, as in prescribing from hospitals fairly soon. Some of the encounters data, and this is particularly critical in primary care, where actually an awful lot of the value from healthcare data is contained within primary care, within GP notes from practice visits. We have an awful lot of observation data, some that combine both primary and secondary care again, and talk a little bit about that in a second. And then outcomes data. So outcomes might be, critical care visits, procedures. It might be deaths, so death data as well. And then on the right-hand side there, that's all linked together with demographics data, which includes deprivation. So SIMD is the Scottish Index of Multiple Deprivation, and ethnicity data as well. So that gives a sense of the data coverage within DataLoch. This really is a view of that data. This is as of 2021, and gives a view of the top conditions based on the Calibre HDR UK phenotyping for the male population within Lothian, and it's a view of the prevalence per 10,000 population. So it gives you a very quick snapshot of what the most prevalent conditions are within the region. We have this view, obviously, is a very helpful view in terms of understanding cohort size, but we have this view for both the male and the female population, and you can see the differences across those. We'll obviously share the slides as well, so you can see this data at your leisure, but it gives a sense of the scale of the data that's available, and the support in terms of multi-morbidity research particularly. The data is actually visible via our metadata catalogue. So the metadata catalogue is available via our website, and the website link is again on the slides. But what we've been trying to do is explain the data in a way that enables researchers and innovators to both understand the specifics of the data source and the variables, but also understand a little bit about the expectations from a DataLoch perspective in the researcher using that data. We are really hopeful that as people do use the data and support research using DataLoch, that actually our metadata will improve through feedback as well. So researchers can tell us what it is that they need to understand in order to make best use of that data, and that can be a continuous improvement process in terms of that feedback loop back into our metadata catalogue. But this gives you a sense of the granularity that is available within that catalogue down to a variable level, and it really gives a nuanced understanding of what exactly is contained within DataLoch as a data service. There is a significant value in combining both primary and secondary care data within a health data service like this. You can see that this just gives a very high-level view of the diagnosis, what population size we have in terms of diagnosis from either GP data or SMR is the Scottish Morbidity Record, which is our secondary care data source, or both. So in a lot of cases, you can see that the population size from our secondary care data, which is the columns in yellow, is quite significant. So cancers, for example, cardiovascular diseases generally are diagnosed via a secondary care service. But in other cases, so skin conditions, for example, neurological conditions, that might be the other way around. You might actually get more valuable diagnosis data actually from our primary care records. So there is a significant value in combining the primary and secondary care data sets to give a more holistic view of a patient's, of a population scale diagnosis across Lothian. And this is a very specific example. So we have been working with the Breathe hub, which is a hub within the health data research HDR UK community, which is looking specifically at respiratory diseases. So we have been working with them to identify a respiratory cohort within the Lothian region, which has 177,000 patients that have asthma within it, 55 patients with COPD, 55,000 patients with COPD, 23,000 patients with ILD. And you can see it actually within the two examples here of asthma on the bottom left-hand side and ILD on the bottom right-hand side. This Venn diagram is actually showing where the condition has been diagnosed in terms of our data. So we have a significant proportion of the asthma diagnosis comes from our primary care data, whereas for ILD, actually a significant proportion comes from secondary care data or even deaths data. And there is a significant overlap between those data sources in terms of diagnosis. We have worked with the Breathe team, which includes clinical experts in the respiratory area, to harmonise this data across 3 different data sets. So DataLoch in Scotland, but also the CPRD data set in England, and the SAIL data bank in Wales. So that enables effectively a 3-nation studies around the respiratory data with standardized data, common data standard across all 3 areas. So that's, when it comes to looking at specific conditions, that kind of deep clinically validated data is really important in terms of individual conditions. But we also leverage the knowledge from our clinical and academic teams in terms of more general data sets. So in this case, measurements data. So on the left-hand side here, again, this is specifically for respiratory, but this data obviously applies across the entire population. And this particular view is just looking at the respiratory conditions. But you can see we have quite good quality data in terms of smoking status and BMI. For the region, and that's actually collated from both primary and secondary care data. So it gives you a kind of sense of the data coverage and the data granularity that is actually part of the DataLoch data service. But there is a specific application process that I just wanted to talk through as well in terms of accessing data within DataLoch. So it's a fairly straightforward process. Our website, so dataloch.org, has a user application portal. You can request an account for the user application portal. It's very straightforward. Press the button, enter your email address, and from there you can access the metadata catalogue to explore the data sets. You can submit an application through that portal. And there are 3 steps to the application process once you've submitted an application. The first step is a review of that application, so making sure that we understand the research purpose, understand what the data requirement is. We will agree the kind of data feasibility and identify any gaps that we might have or any data quality issues, and agree the costs of that project as well, all in that kind of first stage of review. The second stage is approval, and I'll talk through what the approval process looks like in a second. And then obviously, lastly, our data delivery process. So our analysts will work on the data extraction and de-identify that data before we transfer the data into the secure data environment. This is the website and the application portal. So anybody who's interested can jump onto the website and just apply for access via the application portal. And that doesn't assume you're going to create an application immediately. It does give you access to the metadata catalog, so you can explore the metadata in advance. So this is what the process looks like, just at the level below, a bit further granularity in terms of the process. The application that was received through the portal actually goes through a process of feasibility and technical specification, which would be in collaboration with yourself as a researcher. Then we go through our approvals process that I'll talk about in a bit more detail, and through to data delivery on the right-hand side. We do work quite closely with the bioresource team, which is, again, specifically within Lothian in southeast Scotland. The bioresource team have access to tissues and other biological data that we can link into projects where that's relevant to the project. That has a very specific governance model around the bioresource team. But this is the approval process more generally. So any projects that come through will go through for Caldecott approval, which is NHS Lothian approval of that particular project. But projects can also go through the other 4 boards that we see here as well. So the ones in blue are standard research governance, which is both Caldecott approval and sponsorship of a project, but also then ethical approval. And all of our projects also go through a public value assessment. So our public reference group will look at every project that comes into DataLoch and make a judgment about the public value of that particular piece of research. And the reason that we do that is obviously from a public perspective. It's critical to understand that the value that the research project is actually adding from a public perspective is proportionate with the level of risk of using sensitive data. So it's really critical that we get a public voice into that discussion. And then on the left-hand side, the green and yellow boxes are dependent upon the type of project. So if we are using bioresource team, then that, as I said, has a very specific governance process for access to tissue samples, etc. And also if the project is with a private sector or third sector organisation looking to create some innovation, whether that's medical devices or AI innovation, etc., that organisation goes through a due diligence check, which again is an NHS Lothian due diligence check. So the secure data environment, so the data is made available via a secure data environment, or a trusted research environment as sometimes called. This is effectively a secure data platform with analytical tools where you can do research, including AI research as well. So we have a very specific AI virtual machine that's base build that's designed within the SDE. The data is de-identified, obviously, before transfer into the secure data environment, and individual level cannot leave that environment. So when people are looking to publish some research, then they can apply for to extract some output from the SDE. That output would be anonymized aggregate data. The individual level data wouldn't leave the environment. The virtual machines obviously are accessed remotely via two-factor authentication, and the virtual machine can be built with software code and packages as approved by the NHS IT security team. And DataLoch would manage all of that approval process. So if there is bespoke software that's needed built within the virtual machine, then that would be something that we would manage on the researcher's behalf. So that's how the process works within our trusted research environment.